I guess what's afternoon now, isn't it here? I'm from Calgary, which is located on traditional territories of the people of Treaty 7 in southern Alberta and also homeland to Métis Nation Region 3 of Alberta. Of course, the mountains are a very special place to me, and I'm really grateful to live and work and play on these lands. So my proposed research is more focused on healthcare provider perspectives on chronic pain, disability, and sexuality, but I'm going to focus on the broader topic. So more focused on disability and sexuality. And under the disability umbrella, I talk about chronic pain. So disability is stigmatized, chronic pain is stigmatized, sexuality is stigmatized. So there's a lot to really unpack. And the sexual lives of people with disabilities are underrepresented both in literature and politics, and really draws a lot less attention than other aspects of disability. So in healthcare, any care related to disability and sexuality really still follows a medical model rather than one based on the social model of disability. So quick bit about me for anyone who hasn't really heard my story before. I've lived with chronic pain for 18 years, but I've also worked as a sexual health nurse, and sexual health is one of my passions. I've been working in the field for about 10 years. So my research interests really combine both personal and professional experience. And here is a really attractive photo of me after one of my first surgeries. I've had 5 major surgeries in the last 5 years. Only one of them wasn't related to EDS. That's where I fell rock climbing 30 feet. Had 17 rounds of prolotherapy, I think, in the last few years, and a bunch of other injections. So, and that's all just to maintain some quality of life. It's basically a full-time job, and I live with a condition called Ehlers-Danlos syndrome. If you really want to follow my journey, I have an Instagram account with EDS. And the zebra is the symbol for Ehlers-Danlos syndrome because medical students have been taught for decades that if you hear hoofbeats behind you, you shouldn't expect a zebra. But actually, sometimes it is a rare condition. And for me, it took me about 15 years to get diagnosed with Ehlers-Danlos syndrome. Okay, I'm going to try to do this. Let's see if it works. I'm going to post a link in the chat, and we're going to do a class activity.
I don't know how to answer that.
So just bear with me. I hope this works. I didn't integrate it.
Our code works. I'm able to get onto
you're able to get in? Yes. Okay.
Yeah.
Okay.
Where did you put it? In the chat, you said?
I haven't yet because I have the wrong thing on my clipboard. So I will go back and pull it from here.
The QR code worked for me too.
Okay, awesome. Okay, we can go back into the view. I will swap here. I have a chat here just in case, and we'll go back to that slide. Ooh, it's working. So I'll give everyone maybe a minute to throw some words in, just whatever comes to mind first when you hear the word disability and sexuality. Oh, thanks, Marin. I assumed we're all professionals, so I mean, let's talk about sex, okay?
Plus the 3-year-old. Plus the 3-year-old.
Well, I mean,
I'm just teasing. I'm teasing.
Good time to start the conversation with your 3-year-old.
I'm not phased in any sort of way.
Maybe just give like 10, 15 more seconds for any last words that people want to add in.
Thank you.
Cool. Oh, there's more typing. Oh, wow. This is juicy. Cool. I think that's pretty good. I really like some of these, and I think that they will resonate hopefully with some of what I'm going to talk about next. But yeah, this is a really well-rounded word cloud, and I really appreciate your answers. So we can take a look. I like, yeah, lots about stigma, sex workers, pain, flexibility. That's interesting. Could be more than one thing. Complex, adaptive, painful, cripping. Yes. Awesome. Underrepresented. Yes. More stigma. Awesome. Okay. So let's carry on. That was fun. Thank you. So there is a term called disabled sexuality, although I kind of see it as interchangeable with disability and sexuality. Basically, it refers to the sexual experiences, expressions, identities, and needs of people with disabilities. And it emphasizes the importance of recognizing and respecting the sexual rights and experiences of people with disabilities. Of course, promoting inclusivity and really making sure that people with disabilities have access, support, and resources that they need to fully express and enjoy their sexuality. But I should also define chronic pain. So pain, I think we've all experienced. That itself is defined as an unpleasant sensory and emotional experience, usually associated with physical damage to the body. Chronic pain then becomes pain that lasts longer than 3 months. And remember, it affects all ages. So chronic pain does not just affect elderly people. Chronic pain can occur without a known cause, after an injury is healed, or after a condition has been treated. And the WHO now recognizes chronic pain as a disease in its own right and not just a symptom of something else. So about 1 in 5 Canadians live with chronic pain, which is just over 8 million. And chronic pain predominantly affects women whose sexuality has also been neglected in the research, and really only in the last couple decades has like women's sexuality research moved beyond just focusing on reproduction. And my master's research, I looked at chronic pain in emerging adult women, and it really confirmed what the literature shows, which is that women with pain frequently have their pain dismissed in healthcare centers, even at multidisciplinary pain centers. So chronic pain is also expensive. This is a little bit of an older statistic, but according to Health Canada, the total direct and indirect cost of chronic pain in 2019 was up to 40 billion, which of course has increased since COVID because we've seen a rise of chronic pain syndromes related to long COVID. So now that we define chronic pain, we can move on to disability. And I do put chronic pain under the disability umbrella, but it's important to remember that not everyone's chronic pain will identify or recognize that they have a disability. But for some people, chronic pain is very disabling. And for the purposes of my research, I do want to focus more on chronic pain, but I recognize that most of the literature and the broader discourse is on disability when we talk about sexuality. So that's why I'm also using disability as a term. And it's really an umbrella term for impairments, activity limitations, participation restrictions. And one thing about disability, so disability studies, they recognize that disability can only be understood as the outcome of social and economic and structural relations. So it's not necessarily the individual's fault they're disabled. It's not the result of body or brain deficits. So it really means what we need to do is deconstruct and challenge the ways in which society disables people and creates this problem of disability. Because I mean, the fact is, like, most of us will experience some kind of disability at some point in our life, whether it's short term or not. So I talked about disabled sexuality. This is more of just like a broad definition of sexuality. On the left is the WHO's term. Essentially, sexuality is the way people experience and express themselves sexually. And it's not just sexual orientation. It's all of the things you see kind of on the right side of the slide. And it's also defined as a central aspect of being human throughout life. So I really like the sexuality wheel on the right. Just like pain, sexuality is not just a physical experience. And so when we look at the sexuality wheel on the right, we can think about how chronic pain might also affect these aspects of sexuality and overlap with some of the risk factors for chronic pain and intersect or influence sexuality and sexual decision making. And then for me, I also wonder, well, how are healthcare providers addressing or not these factors on the wheel in relation to chronic pain and sexuality? So care providers do need to consider all of these parts when working with people with chronic pain, because it affects self-image, body image, communication, and experiences that shape the values and beliefs that a person has about themselves as a sexual being. So I'm going to talk a bit more about background. And when I talk to colleagues about chronic pain and sexuality, I mentioned my research interests, they kind of immediately jump to like chronic pelvic pain or pain with sex. But we overlook that chronic pain is with sex is also just generalized chronic pain, or people live with chronic pain elsewhere, and that still affects people's sexuality because it's their identity. So there are different psychosocial risk factors related to the development of chronic pain. I won't go into all of them now, but interestingly enough, when we talk about sexuality, bisexual women and lesbians are actually at greater risk than heterosexual women for certain chronic illnesses, probably because of stigma around their sexual identity. And previous abuse or sexual trauma also increases risk for chronic pain. We know that women experience the majority of gender-related violence as well as chronic pain. And so there's a lot of intersectionality between the risk factors for chronic pain. There's a very high prevalence of sexual dysfunction in people with chronic pain. The numbers vary, but it's been as high as 73% in some studies. And even in interdisciplinary pain centers, though, about 60% of patients say that their treatment didn't address their sexual functioning. And the typical multidisciplinary pain management models is not sufficient to address patients' concerns with sexual functioning. So there's some research on chronic pain and sexuality from the patient perspective, but there's very little on healthcare providers themselves in relation to chronic pain and sexuality. I haven't found any articles that focus on sexual health nurses or providers in sexual health settings with a chronic pain context, and none that actually study nurses in relation to chronic pain and sexuality other than just focusing on pelvic pain. The majority of patients, no surprise, are reluctant to raise their sexual concerns with their healthcare provider, and it goes the other way too. So healthcare providers rarely initiate conversations with patients around sexual health. So really, healthcare providers often fail to address chronic pain. They often fail to address sexual health. Their knowledge is limited on both. So what might their perspective be on the two combined? And that's what I'm interested in. Little bit more background just around kind of some historical context. So people with disabilities have long been labeled as asexual, seen as undeserving of sexuality, not deserving of pleasure or love. They've been denied sexual rights, adequate sex education, discouraged from having children, even sterilized involuntarily. So sexual ableism is a term used to describe the discriminatory manifestation of lowered sexual expectations for people with disabilities, and that can be individual attitudes, but also through institutional policies and procedures. And the originator of crip theory says able-bodiedness is the foundation of sexiness. And so people with disabilities have been desexualized over time. And stereotypes suggest, of course, disabled folks are not assumed to be sexually attractive or desirable. And sexual dysfunction is defined as anything that doesn't fit typically like ableist, heteronormative sex. And that can further pathologize sexuality among people with disabilities. So sexual health is very much deficit-based in my experience, whereas if you have a disability, you don't have sex according to the norm, then you therefore have sexual dysfunction. And in society, it's kind of similar. So this tragedy model tends to prevail where disabled people are defined by their deficit, and sexuality is either not a problem because they're not having sex, or it's an issue because they're seen as the problem. So there's really a gap on this discourse around sexuality and disability, especially for women. And researchers, even in the disability community, have dismissed the topic of sexuality. So there's also this kind of missing focus or emphasis on pleasure in that discourse. And sexual health, like I mentioned, it's very much about the biomedical model, and it's still somewhat sex negative. So it's focused on preventing things like STIs. If you have sex without a condom, the world's going to end. Yes, condoms are great, but let's move beyond that. So historically, non-disabled people, actually, interestingly enough, non-disabled people who had troubles having orgasm, like anorgasmic, that's what it's called, would qualify for treatment, but people with a disability who had the same problem, couldn't orgasm, were excluded from treatment. So there's a need for the disability movement to advocate for access to pleasure in disability studies, politics, healthcare, and even the public discourse. So why does this matter? Sexuality is an important aspect of wellness. I think hopefully you all enjoy having sex if you choose to have sex. And so everyone has a right to healthy sexuality, regardless of their abilities or health conditions. And the WHO recognizes sexuality as a human right. While disability rights groups have worked really hard to address lots of other ways people with disabilities are oppressed, less attention has been directed at gaining sexual rights. So if you think about it, like what happens when an ableist culture depicts people with disabilities as asexual, lacking sex feelings, desires, or they're sexually inadequate, what happens is they're then seen as not in need of sexual rights like able-bodied people are. So sexual health is also a human right. Sexual rights are human rights. And for sexual health to be attained and maintained, the sexual rights of all people need to be respected, right? And for the record, the WHO definition of sexual health does actually talk about pleasure. And it states sexual health is not just the absence of disease or dysfunction. So the application of existing human rights to sexuality and sexual health basically constitutes sexual rights, and that includes access to sexual citizenship. And these sexual rights are embraced in international and other documents around human rights. So, for example, the UN Convention on the Rights of Persons with Disabilities, Article 23 and 25 are both fairly relevant. So, Article 23 supports the rights of people with disabilities to form relationships, reproduce, have families. And then Article 25 advocates for equal access to comprehensive health services, which also includes sexual and reproductive health. So furthermore, back to chronic pain. So chronic pain increases risk for substance use. Substance use increases risk for chronic pain. And the use of substances increases risk for negative sexual health outcomes like STIs, unintended pregnancy, unwanted, unplanned sex. And then if you maybe throw some like sexual trauma in the mix, it becomes even more complicated. And it's important to understand that people with chronic experience often experience medical trauma from being dismissed, having their pain dismissed in the healthcare system. So they probably can also be very hesitant to access healthcare for that reason. Disabled people also may access services to support their sexual needs. Sometimes that's provided what's called sex doulas, if they can afford it, because it's typically not covered in Canada. But sometimes it's really the only way that a severely disabled person can meet their sexual needs. They may also engage in sex work. 73% of sex workers surveyed in one survey said that they were living with at least one disability. And because many people with disabilities face workplace discrimination or lack of accommodations, they may not be able to work like a quote unquote normal job. And so engaging in sex work can offer them some financial autonomy, but doesn't come without risks in our Canadian system, right? Another interesting fact is that I didn't know this, but many people with chronic pain participate in BDSM or kink, and they're more likely to gravitate to it than non-disabled folks. And it can be a way to actually help manage with their pain and then also ground in their bodies. It's a bit of a reclaiming phenomenon. But of course, there's a risk for physical injury, which can have a greater implication with chronic illness or chronic pain. So it's important that we're able to have honest, meaningful discussions as healthcare providers with people that have pain or disabilities around their sexual health and their sexual practices. And then finally, people with disabilities experience higher rates of sexual violence than non-disabled people. So yes, they can be vulnerable to exploitations. And remember that experiences with sexual assault shape a person's relationship with sex and their own sexuality. So my proposed research will use narrative inquiry to understand how sexual health nurses attend to all of this. What do they think of chronic pain and sexuality? And so I'm using Clandon and Connolly's form of narrative inquiry, qualitative relational methodology, and it focuses on human experience as a source of knowledge. Relationships with our bodies are so complex. If you throw chronic pain in there, it's even more challenging. So I'm curious how sexual health nurses' relationships with their own bodies and their own understandings of sexuality and chronic pain influence their practice. So I will recruit 3 to 5 registered nurses through Alberta Health Services clinics that I have worked at. These are sexual health clinics. And I'm already connected to the programs. I worked in the nursing role, so I come with an understanding of the work and I have good relationships with the managers. So what am I hoping for? Well, I do hope to understand limitations in sexual health care of chronic pain patients. Nursing is really a reflexive practice, but the time just isn't there anymore for nurses to reflect on who they are and how that influences their practice. There's really a curiosity towards experience and individual experience that's missing from healthcare interactions. And I also hope to identify systemic and institutional barriers that nurses experience in their sexual health practice. I also aim to identify assumptions and biases of sexual health nurses towards patients with chronic pain so that I can begin to address them and improve how healthcare providers attend to patients with chronic pain. So narrative inquiry can create new possibilities to act differently by revealing counter narratives, and these are narratives that can resist dominant stories. So by first understanding nurses' perspectives, the dominant narratives of chronic pain and sexuality can start to be disrupted and may alter how providers attend to patients with chronic pain. Finally, if nursing practice is shifted, it can reduce adverse outcomes for chronic pain patients related to sexual health by restoring trust in relationships with the healthcare system for chronic pain patients. And we also know that early and appropriate intervention with chronic pain patients accessing sexual health can reduce those adverse sexual health experiences we care so much about, which are very important for public health reasons, but like STIs, and it can also empower patients with chronic pain in their sexuality because at the end of the day, sexual health is a human right, and we are all sexual beings. So thank you for coming to my TED Talk. If you want my reference, let me know, and I'm happy to take any questions.